Right now, I want you to run your fingernails very lightly across the back of your forearm, just once, slowly, and notice what you feel. For most people, that sensation is neutral, a mild touch. For a significant percentage of adults over 60, that same light contact produces an exaggerated urge to scratch. If you are one of those people, if your skin responds to that lightest touch with a disproportionate itch, or if you find yourself waking up at 2 or 3 in the morning reaching for your arm, your leg, your back, without any rash, without any visible irritation, without anything a tube of moisturizer has ever fully resolved, I need you to stay with me, because what I'm about to explain may be the first time someone has told you the truth about what is actually happening. Most doctors, when a patient over 60 describes itching skin, reach for one word: dry. Dry skin. Here is some lotion. Come back if it gets worse. And for some people, that is the right answer. But for a meaningful percentage of patients in this age group, nighttime itching that does not respond to moisturizer is not a skin problem. It is a signal from somewhere else in the body. It is your liver, your kidneys, your nerve endings, your thyroid. And understanding which one is sending the signal is what determines whether this is a nuisance or something worth addressing urgently. My name is Dr. James Harlow. I have spent over 25 years in internal medicine, and I can tell you that chronic itch in older adults is one of the most undertreated and underinvestigated symptoms I encounter in clinical practice. Studies estimate that up to 37% of adults over 65 experience chronic itch, a prevalence higher than arthritis in some populations, and the majority are never evaluated for systemic causes. Today, I'm going to give you that evaluation. If you are not yet subscribed to this channel, please do that now. I publish these videos every single week. Subscribe and ring the notification bell. Let me walk you through the real causes of nighttime skin itching in seniors, from least to most serious. Cause number 5 is xerosis, true dry skin, but not the kind you treat with lotion alone. After 60, the skin's natural oil production decreases, the skin barrier becomes thinner and less effective at retaining moisture, and transepidermal water loss increases. All of this is real and does contribute to itching. But the important distinction is that xerosis-related itch is usually diffuse, improves with consistent moisturizer use, and is worse in dry winter air. It does not typically wake you from sleep. It does not concentrate in the torso or lower legs, and it does not fail to respond to any amount of topical treatment. If you have been using a good fragrance-free emollient consistently and the itch persists, you are past the dry skin explanation. Cause number 4 is medication-induced pruritus. This is one of the most overlooked causes of chronic itch in older adults, and I bring it up with almost every patient who presents with this complaint, because the medication list tends to grow in this age group. Certain blood pressure medications, particularly ACE inhibitors and calcium channel blockers, are known to cause skin itching in a subset of patients. Diuretics can contribute through the dehydration they cause. Statins have been associated with itch in some individuals. Certain antibiotics, antifungals, and even aspirin can trigger mast cell release that produces itching. A review published in the Journal of the American Academy of Dermatology specifically identified polypharmacy, taking 5 or more medications simultaneously, as a significant independent risk factor for chronic pruritus in adults over 65. If your itch began or intensified around the time a new medication was added to your regimen, that timeline is worth exploring with your physician. Cause number 3 is neuropathic itch. Itch that originates in the nervous system rather than the skin. After 60, peripheral nerve function begins to change. Small nerve fibers that carry sensory signals, including the signals that distinguish touch from itch, can become sensitized or damaged. This produces what clinicians call neuropathic pruritus, an itching sensation that occurs without any external trigger and without any skin change. The most common cause of this pattern in this age group is post-herpetic neuralgia, nerve damage that persists after a shingles outbreak. Research published in the journal Pain found that pruritus is a significant but underreported symptom in post-shingles patients, affecting up to 30% of those with post-herpetic neuralgia. Neuropathic itch tends to be localized to a specific area rather than diffuse, and it may coexist with mild burning or hypersensitivity in the same region. Diabetic peripheral neuropathy. Nerve damage from chronically elevated blood sugar can produce a similar pattern, often concentrated in the lower legs and feet. Cause number 2 is kidney disease, specifically what is called uremic pruritus. The kidneys filter waste products from the blood, and when their function declines, certain compounds accumulate that the body cannot eliminate efficiently. These compounds, including phosphate and various uremic toxins, are deposited in the skin where they activate itch receptors in the nerve endings. Uremic pruritus is one of the most distressing symptoms of chronic kidney disease. It is typically worst at night, when the body is in a more horizontal position and blood circulation patterns shift. It tends to be diffuse, affecting the back, abdomen, and limbs rather than the face. A study published in the American Journal of Kidney Diseases found that between 40 and 50% of patients with moderate to advanced chronic kidney disease experience significant pruritus, and the correlation between itch severity and kidney function decline is well established. Because kidney disease progresses silently for years, nighttime itch may be among the earliest symptoms a patient notices. Cause number 1. The cause I want to address with the most detail is liver dysfunction and impaired bile flow. This connection is less well known among patients, and I believe it is one of the most important things I can share in this video. When the liver is not functioning optimally, or when the bile ducts that carry bile from the liver to the digestive system are partially obstructed or inflamed, bile salts and bile acids accumulate in the bloodstream. These compounds are deposited in the skin, where they directly stimulate nerve endings and cause intense, generalized itching. This type of itch is known as cholestatic pruritus, and it has a very characteristic pattern. It is almost always worst at night and in the evening. It is frequently most intense on the palms of the hands and soles of the feet, and it is often not accompanied by a rash or visible skin change. A patient presents with severe nighttime itch, looks at their skin, sees nothing, and is told it is dry skin. Research published in the Journal of Hepatology examining patients with early-stage liver conditions found that pruritus was often the presenting symptom, appearing months before jaundice, fatigue, or elevated liver enzymes on a standard blood panel. This is what makes it so important. The itch may come before the diagnosis. Conditions associated with cholestatic pruritus include primary biliary cholangitis, non-alcoholic fatty liver disease, which affects an estimated 30% of adults in the United States, and gallbladder dysfunction. I want to pause here. If this is resonating with something you have been experiencing, leave a comment below telling me about it. Have you been told it is just dry skin? Have you tried moisturizer without relief? I read every single comment. Now let me talk about risk factors and what to do. You are at elevated risk for systemic causes of nighttime itch if you have known kidney disease, liver disease, or diabetes. If you have had shingles, particularly in the past 2 years. If you take multiple medications. If the itch is concentrated in specific patterns. Palms and soles suggest bile acids. Back and torso suggest uremic causes. Localized bands suggest neuropathic origin. Here is your action protocol. Step 1. Keep a 1-week itch diary. Note the time the itch occurs, the location on your body, the intensity, and any pattern. This information is clinically useful in distinguishing between the causes I described today. Step 2. Ask your doctor for a targeted blood panel. This should include comprehensive metabolic panel to assess kidney function, creatinine and eGFR, and liver function, ALT, AST, bilirubin, and alkaline phosphatase. Also request a thyroid panel, as hypothyroidism is another systemic cause of diffuse itch. And if you have not had a fasting glucose and HbA1c recently, add those as well. Step 3. Review your medication list with your physician specifically in the context of the itch. Ask directly, could any of these be causing or contributing to the itching? Step 4. If the blood panel is normal and medications are ruled out, ask for a dermatology referral to evaluate for small fiber neuropathy or other dermatological causes. Step 5. Do not continue to attribute persistent nighttime itch to dry skin if moisturizers have not resolved it after 2 to 3 consistent weeks of use. You deserve a real answer. If this video gave you something worth sharing, please send it today to someone you care about who has been dealing with this. Subscribe to this channel and leave a comment below telling me whether you have been living with unexplained itching and whether you have ever been evaluated for any of these underlying causes. I read every one. I am Dr. James Harlow. Take care of your liver. Take care of your kidneys. Your skin is trying to tell you something. I will see you in the next video.